So, dear ladies and gentlemen, my name is Thomas Kriebel from Kaiserslautern in Germany, and I'd first like to thank Edward and John Treitman and all the other organizing members of Pediatric 10 for inviting me to give this talk. And I hope I see you all live in Boston. And I note that I have nothing to disclose. So coming into the material into the late 80s, the atrial switch procedure became the mainstay for surgical treatment for d-Transposition of the great arteries. In the Senning operation, an atrial buffer is created with autologous tissue using an atrioceptive flap or tissue from the right atrial appendage to redirect venous return to the mitral valve and suprapulmonary left ventricle by using this atrioceptive flap. And in the mustard procedure, normally pericardium is used to create the intra-atrial buffer, which is in contrast to the Senning procedure, no myocardium. So these operations provided excellent early and midterm results. However, in the meanwhile, it became evident that both procedures were associated with long-term sequelae such as arrhythmias, right ventricular dysfunction, tricuspid insufficiency, buffer-related complications, and primary hypertension and sudden cardiac death. In this large study from 2015, you see the clinical outcome after atrial switch procedure in 468 patients from Sweden and Denmark. The perioperative mortality was 20% and 60% of the patients were alive after 30 years of follow-up. These are data from a meta-analysis of 33 studies from 2019, which more than 5,000 patients included. The survival rate was 65%, 40 years after atrial switch procedure. But which is very quite important is that 89% of the patient died due to cardiac causes, with sudden cardiac death being the most common cause, followed by heart failure. And the incidence for sudden cardiac death was 5.6 per 1,000 patient years. Significant risk factors for sudden cardiac death included history of SVT, the mustard procedure, and complex d-Transposition of the great arteries. The most common arrhythmias after atrial switch procedure for TGA are sinus node dysfunction, with approximately 40% after 20 years post-surgery, and intra-atrial reentrant tachycardia, mostly involving the carbotricuspid isthmus, with an incidence of approximately 35% 20 years post-surgery, and focal atrial tachycardia and other arrhythmias can occur but are more infrequent. On this slide, you see the clinical course of adult patient after the mustard procedure. And 40% of the patient had at least one episode of SVT at the age of 30. Intra-atrial reentrant tachycardia are the most common form of SVT, and these tachycardia develop not only because of natural conduction barriers like the crista terminalis or the valve annuli, but also because of fibrosis related to suture lines and patches. Risk factors for the development of intra-atrial reentrant tachycardia are pulmonary hypertension, right ventricular dysfunction, or junctional rhythm. The risk for sudden cardiac death is increased by SVT up to 4.7-fold. And SVT can cause rapid ventricular response, followed by ischemia-related ventricular tachycardia, and finally ventricular fibrillation. So possible therapy of SVT in patient after atrial switch procedure include antiarrhythmic drugs, anti-tachycardia pacing, and ablation. So looking at the antiarrhythmic medication is often unsatisfactory due to inadequate efficiency and combined with potential side effects. And this old study by Glessen and colleagues from 1985, the overall success rate of any drug treatment or combination of drugs in completely eliminating episodes of atrial flutter in patients with congenital heart defects, not only atrial switch, was 58%. And note at that time, however, digoxin was often used alone or in combination. In addition, the medication, some of the agents have potentially negative inotropic effects, especially in patients with an often impaired RV function, and you have to consider lifetime use of the medication. In some contrast to the study from Glessen, Carey and co-workers showed that beta blockers in 37 mustard and Senning patients after ICD implantation we reduce significantly the number of appropriate ICD shocks, as you can see in this picture. However, the effect of beta blockers is probably multifactorial. We don't see here a reduction of SVT, but we see a multiple factorial effect of beta blockers for maybe due impairment of rapid ventricular response to SVT, reduction of myocardial ischemia, and suppression of VT, but also possible suppression of SVT. Therefore, I've already treat patients after atrial switch with short document SVT episodes already with beta blockers. However, catheter ablation has become the treatment of choice for SVT in patient after atrial switch procedure. As intra-atrial reentering tachycardia are the most common form and often the carbotricuspid isthmus is a critical part of the reentering circuit, knowledge of the electrophysiological anatomy is of paramount importance, for example, that the left atrial appendage drains in the systemic venous side. Here you can see an internal view by Cantor and co-workers of the pulmonary venous atrium from a right lateral perspective in A and C after the A mustard and in D after the Senning procedure. And as you can see here, the AV node is in the pulmonary venous atrium and the suture line of the inferior baffle bisects the CTI. And as the suture line posterior of the coronary size, as in A, as you can see here, the CTI and the CS are on the pulmonary venous side. And if the suture line is posterior of the CS with redirected ostium in the systemic venous atrium, the CTI is on both sides. And in case of an anterior suture line, as you can see here, the large portion of the CTI and the CS on the systemic venous side. And in patient after the Senning procedure, the CS and large portion of the CTI are on the pulmonary venous side. Before performing a catheter study in a patient after atrial switch, you should read the original surgical report with special attention regarding the suture lines, we just discussed that, and the position of the CS ostium. Pre-procedural, you may do pre-procedural imaging like an MRI or CT or an angiography, as in this 36-year-old patient after the Senning procedure for DTGA and implantation of this LVPA conduit due to a suprapulmonary stenosis, for example, to delineate the intra-atrial anatomy or to rule out baffle obstruction. Be aware of possible hemodynamic instability during the study due to quick ventricular rate response to SVT. We just discussed that. Here you see the surface ECG and intracardiac ECG tracing in a 20-year-old patient after mustard procedure for DTGA. And he had an additional pacemaker implantation for sinus node dysfunction. And he came for a catheter ablation for recurrent SVT to our lab. And at the beginning, after induction of an intra-atrial reentering tachycardia, there was mostly or often 2-to-1 AV conduction. However, during the time, rapid ventricular response was noted with subsequent ventricular tachycardia. We have one beat by the pacemaker, and finally, they end up in ventricular fibrillation with requiring external defibrillation. However, we continued then the procedure after administration of metoprolol. We need also some arterial for blood pressure, with subsequent, however, 2-to-1 AV conduction. However, by using, for example, metoprolol or verapamil, you may also terminate SVT with subsequent non-inducibility of the tachycardia. You have to take this into account. I normally implement an arterial line for continuous blood pressure control and a urine catheter to control the urine output. In addition, this increases the patient comfort and reduces medication for sedation. In addition, think of organizing a post-interventional ICU bed. I normally introduce 3 venous Cs, one for RV pacing, and the second, a multipolar catheter position in the left atrial appendage, also used as a reference catheter. An alternative is a position of the multipolar catheter in the intracaval tube or a small screw-in atrial lead as reference. The third venous sheath is used for the mapping ablation catheter. I normally introduce an arterial sheath as an alternative for the arterial line for the blood pressure control and also to perform a coronary angiogram, what we do prior ablation, and for a possible retrograde approach. Nowadays, you should use modern mapping system, and you may merge MRI or CT data. You also should use high density mapping. I normally use an advisor high grid, just by the fact that I'm lucky that I have both CART and Insight available in my lab. Perform an LAT activation map, where you look out for head meets tail for intra-atrial tachycardia, or a centrifugal activation pattern for focal atrial tachycardia. Use a voltage map to identify scar areas, and use concealed entrainment as in this 16-year-old patient after master procedure in your targeted isthmus. Normally, you need to access the pulmonary venous atrium for ablation of intra-atrial tachycardia to reach the CTI, and some colleagues use the retrograde approach by passing the aortic valve, and however, I find navigation in the pulmonary venous atrium limited. This may in part be overcome by the use of remote navigation, which is, however, sparsely available. So I normally perform a transbuffal puncture to delineate the anatomy and the position where I'm going to puncture. I like to have the position of the systemic and pulmonary venous atrium. And therefore, I perform an angio in the IVC, in the SVC, and also in the right pulmonary artery. And after for puncture, I use an Achilles sheath and advanced support wire. Sometimes you need additional dilatation, not very often. And you also might use ICE or esophageal echo for additional guidance. And sometimes, as in this example, I also perform an angiogram afterwards of the pulmonary venous side, also to have a good view of the anatomy. And during the mapping and ablation of the pulmonary venous atrium, the activated clotting time should be more than 250 seconds. So these are pictures from the 36-year-old patient with DTJ and subpulmonary stenosis. We saw some pictures earlier. And we performed the EP study after programmed stimulation. You can see an intra-atrial tachycardia with a 3:1 and 2:1 AV conduction with a cycle length of 327 milliseconds. On the right side, you can see the Achilles sheath already in the pulmonary venous atrium, and the advisor high-degree catheter in the systemic venous atrium. You can see now the LAT map of the intra-atrial tachycardia in the same patient using the Insight precision system. And you can see the systemic and venous atrium. This is systemic and this is pulmonary venous atrium in a right lateral view and in a 60-degree LRO view. Analysis of the endocardial activation pattern revealed an intra-atrial tachycardia circulating counterclockwise around the tricuspid valve involving both atria. On this slide, you can see the same tachycardia again. On the left-hand side, same view. On the right side, you see a bottom view now. Again, the CTI can be noted as the shortest isthmus to target. A linear RF lesion line was performed using an irrigated tip from the tricuspid valve annulus to the IVC on both sides with termination of the SVT during ablation. Now you can see the induced RF lesion line, again in right lateral and bottom view. You can see it goes by both atria, and after termination of the intra-atrial tachycardia, complete block was noted along the line by stimulation from the systemic venous atrium. We can see we only have counterclockwise around the both atria with complete block along this line. So looking at success and recurrence rate in several studies, around 29, I might have missed some. A success rate of catheter ablation of SVT in patients after atrial switch procedure of around 67 to 86% has been described. Recurrence rates were noted up to 33%, and in a more recent study from this year, actually up to 58%. In the latter study, at least the arrhythmia burden could be significantly reduced. The CTI was a critical zone of slow conduction in patients with intra-atrial tachycardia in 75 to 90%. Other circuits are present, but more seldom, for example, around the pulmonary veins or the IVC orifice. Ablation was successful when only performed in the systemic venous atrium in 10% of the patient, and in 50–70% of the patient when only performed in the pulmonary venous atrium. Some studies use irrigated tip catheters. However, you should pay attention of the additional fluid in congestive heart failure. Finally, in some studies, also contact force is additionally used. So at this point, I'm happy that you're still here. Perhaps some of you thought you don't have to listen to this talk, as ablation in patients after arterial switch will become historic, as the arterial switch procedures nowadays performed in patients with DTJ. So can you go for a coffee break? Should not, as you still need this knowledge in the future, and I will show you why. So this is an angiogram of this three-day-old patient with inverted ventricles and atrioventricular discordance and ventricular arterial concordance, plus a VSD and a non-restrictive ASD. So on the left side, you see the angiogram of the right ventricle with a catheter coming from the IVC through the right and subsequent left atrium in the right ventricle. From the right ventricle, you see the pulmonary artery coming out. And this is the angiogram of the left ventricle with a catheter to the IVC, right atrium in the left ventricle, and from the left ventricle, you see coming out the aorta. So in this patient, a Senning procedure was performed at the age of 6 months. So after the Senning procedure, the patient was regularly seen by a local pediatric cardiologist. However, 3.5 years after the Senning procedure, at the age of 4, the patient was admitted with this broad complex tachycardia in a local hospital. They gave amiodarone, and you can see that an intra-atrial tachycardia was present. And after cardioversion, the patient was transferred to our department with impaired ventricular function. So we treated the patient with Sotelo. I didn't perform the catheter ablation yet because of the body weight of the patient. And also the question arises where in this heart failure where the Grea is a conduction system. So this is the only patient I ever did actually an electrophysiological study under medication to control if this medication is actually effective. It's something actually to discuss, and I'd like to have your opinion about that. And I did some angiograms to show we have good postoperative results, and during program stimulation, no uncastened SVT or VT could be induced. However, under sedation, actually, this patient is additionally scheduled for an additional loop recorder implantation. So in addition, the atrial switch procedure is also used in the double switch procedure in patients with CCTGA, as you can see on the left side of the slide. So in these patients, the normal AV node is hypoplastic and cannot connect with the atrioventricular bundle. Instead, there's this anterior AV node located below the orifice of the right atrial appendage, close to the lateral margin of the area of fibrous continuity between pulmonary and mitral valve. There's an angiogram of the SVC on the left side of the slide showing the systemic venous atrium in the 13-year-old patient with CCTGA, VSD, and left ventricular outflow tract obstruction after double switch procedure and VSD closure, and the resection of the LVOTO. And you can see quite nicely the Senning procedure, and you also can see there's still some residual left ventricular outflow tract obstruction. So I performed an electrophysiological study to recurrent episodes of subjective, however not documented tachycardia, and after a syncope and during programmed atrial stimulation, intra-atrial renton tachycardia with a cycle length of 240 milliseconds could be induced. Due to the displayed AV node, I had not performed the catheter ablation in a patient after double switch procedure. At that time, I decided 6 years ago to do this procedure with Joachim Heber, who told me he had performed this procedure in the past. So this is slides from the investigation we did together, and you can see the electroanatomical mapping using the Carter system, left in 30 degrees RO and a 60-degree LRO projection of the same patient. And stimulation from the posterior systemic venous atrium showed counterclockwise as well as clockwise, so both direction around the mitral valve annulus. And mapping during tachycardia, which is not presented here, showed counterclockwise conduction through the isthmus between the mitral valve and the inferior cava vein. So after induction of an RF lesion line between the mitral valve annulus and the IVC, stimulation from the posterior systemic venous atrium showed a complete conduction block along the line with only counterclockwise now conduction to the anterior portion of the pulmonary venous atrium. So ladies and gentlemen, I'd like to conclude. Sudden cardiac death is the most often observed cause for late mortality in patients after atrial switch for d-Transposition of the great arteries. SVT increased significantly the risk of sudden cardiac death in these patients. As antiarrhythmic treatment is often unsatisfactory and often combined with serious side effects, catheter ablation of atrial reentering tachycardia is the treatment of choice in patients after atrial switch for d-Transposition of the great arteries. Most common SVT are intra-atrial reentering tachycardia with tricarbotricuspid isthmus as part of the reentrant circuit. In most patients, ablation of the CTI has to be performed from both atrial sides. Despite the fact that atrial switch operation for patients with DTGA is no longer used, the pediatric electrophysiologist is still facing older patients with DTGA after atrial switch, as well as patients with CCTGA after double switch procedure. Thanks for your attention.